Welcome to the Insights at ACR 2020 series, brought to you by the Cytokine Signalling Forum, where authors reviewed their Congress posters and presentations on cytokine signalling and JAK inhibitors. My name is Professor Chris Edwards from the University Hospital Southampton in the UK. This edition looks at JAK inhibitors beyond the treatment realm of RA and features presentations from Professors Iain McInnes, Xenfon Baraliakos and Buch. The first two presentations are from CSF Steering Committee Chair Professor Iain McInnes and focus on upadacitinib in psoriatic arthritis. In the first presentation, he analyses the efficacy and safety of upadacitinib versus placebo and adalimumab.
Well, hello, my name is Iain McInnes. I'm the Muirhead Professor of Medicine and the Versus Arthritis Professor of Rheumatology at the University of Glasgow. And it's a real pleasure for me to tell you about this phase 3 clinical trial, the SELECT PSA-1 study, in which the efficacy and safety of upadacitinib was compared to placebo and also adalimumab in people with active psoriatic arthritis who had previously failed non-biologic conventional DMARDs. Now, I think the relevant background, I'm sure most of you are aware that upadacitinib is an orally bioavailable JAK inhibitor with relative selectivity for JAK1. It's already approved for the use of people with active rheumatoid arthritis. So what about its potential in psoriatic arthritis? Well, the basic design here was parallel randomized double-blind administration of 15 milligrams or 30 milligrams of upadacitinib, 40 milligrams adalimumab every other week, or placebo. Approximately 430 group patients are allocated to each group. The placebo is actually split into two arms to properly randomize against upadacitinib and adalimumab. And the baseline demographics for this were pretty typical for a psoriatic arthritis population, 50-50 split roughly for males to females, patients in the order of 50 years of age. Caucasian white predominance is very often the case in such studies. And the body mass index high, in the order of 30 as a mean, reflecting the demographic and the reality, which is that cardiometabolic syndrome is pretty prevalent in people with psoriatic arthritis. Baseline disease activity, well, again, fairly typical for this kind of phase 3 population, in the order of 20 tender and 11 swollen joints with a HAC in the order of 1.1, 1.2. And about a half of the patients had a body surface area greater than or equal to 3%, which was therefore evaluable for changes in skin disease activity, and that's important for the data that I'll talk about momentarily. So there was a hierarchical statistical analysis, which for those of you who are interested in such things, achieved its statistical approval right through to line 9, which was changed from baseline in fatigue score. But that meant that a comparison of the ACR 20 responses for superiority of upadacitinib versus adalimumab could not be formally tested. So the hierarchy broke at line 9. So if you go back and peruse the presentation in detail, that will be helpful to you in navigating the data. But for purposes of this short presentation, let me just highlight the key observations. Well, first of all, the ACR responses at week 12, the non-responder imputation demonstrated very robust improvements in ACR 20, ACR 50, and ACR 70 for both doses of upadacitinib, with superiority, in fact, over adalimumab for the 30 milligram dose of upadacitinib. So this was something in the order of 79% of patients achieved in ACR 20 and 50% of patients achieved in ACR 50 at 12 weeks in response to 30 milligrams of adalimumab. Possibly more relevant to clinical practice given the more likely use of 15 milligrams of upadacitinib, that 70% of patients achieved in ACR 20 and 38% in ACR 50. So really very robust responses, and these were manifest and statistically evident in as early as 2 weeks after the commencement of therapy and were sustained through to week 24, which is the duration of this particular report. We saw resolution of enthesitis as assessed by the lead enthesitis index in 58% of patients at week 24 in the 30 milligram group and 54% in the 15 milligram group, as opposed to 47% of patients receiving adalimumab. And when we looked at dactylitis using the LDI, we had 80% of patients with resolution of dactylitis by week 24 in the 30 milligram group, 77% in the 15 milligram group, and 74% in the adalimumab recipients. Now, what was really interesting here was we then looked at PASI responses, and the responses here were rather gratifying, and I think for me a bit surprising in terms of an oral JAK inhibitor, such that a PASI 75 was elicited in 63% of patients receiving 15 milligrams of upadacitinib, as opposed to 53% receiving adalimumab, 21% in the placebo group. But actually the PASI 100 rate was achieved in 34% of the 30 milligram group, 24% of the 15 milligram group, and 20% of those patients receiving adalimumab. So robust responses in several domains. What about those achieving minimal disease activity? Well, this was achieved by 37% of patients receiving 15 milligrams of upadacitinib, 45% of patients receiving the 30 milligrams, and around a third, 33% receiving adalimumab. No surprise, therefore, that we also saw improvements in the HAQ Disability Index, pain, SF-36 physical component score, and FACIT fatigue score at week 12. And these were all highly statistically better in the upadacitinib arms as compared with placebo. And finally, turning to the important matter of radiographic progression, we saw statistically significant improvement in erosion and overall improvement in total sharp score progression, which was achieved and measured at week 24 for both doses of upadacitinib and, of course, for adalimumab. To balance, of course, the efficacy data that I've shared with you, you should be aware that the treatment emergent adverse event profile was satisfactory. There were no new signals emerged in this study that were not expected from those previously performed in people with rheumatoid arthritis. So the conclusions we draw from this are that upadacitinib at 15 and 30 milligram demonstrated superior efficacy compared to placebo in treating psoriatic arthritis symptoms and signs in people refractory to non-biologic DMARD therapy. In terms of the ACR 20 response, at week 12, both doses achieved non-inferiority versus adalimumab, and the 30 milligram dose achieved superiority to adalimumab. And that efficacy onset was observed as early as week 2. And upadacitinib inhibited radiographic progression, which is very gratifying for use of a JAK inhibitor. And the safety profile was consistent with that we've seen in previous upadacitinib studies. So those are, I hope, useful informations for you. Upadacitinib looks like a very interesting addition to the armamentarium in the treatment of people with psoriatic arthritis, and I commend this study to you for your attention. I hope, of course, in these challenging times that this has been useful to you and that you will stay well and healthy. Thanks so much for your attention.
Staying with upadacitinib in psoriatic arthritis, this time Professor McInnes analyses the impact of upadacitinib on pain.
Well, hello, my name is Iain McInnes. I'm the Muirhead Professor of Medicine and versus Arthritis Chair in Rheumatology in the University of Glasgow. Thanks so much for your interest in this poster. It's a really important topic. It's looking at how we manage pain in people with psoriatic arthritis, and in particular, it's focusing down on the utility of upadacitinib in the management of people with pain as association with their psoriatic arthritis. I'm happy to tell you about this on behalf of a very learned authorship, including colleagues Phil Mees, Kurt de Vlaam, and others. So the purpose here was to look at actually a combined analysis of the two pivotal phase 3 trials that have led to the increased understanding of the role that upadacitinib has in the treatment of people with psoriatic arthritis. And these are called Select PSA1 and Select PSA2. The Select PSA1 study was patients who had an inadequate response to non-biologic DMARDs, whereas the Select PSA2 was patients with inadequate response to biologic DMARDs. And there was a background conventional DMARD allowed in these studies, comparing 15 milligrams of upadacitinib and 30 milligrams of upadacitinib. And in Select PSA1, there was an additional adalimumab comparator arm, so alongside placebo in both trials. So if you want to see the details of the study design, please look at the poster and direct your attention to the figure 1. Now, what we did for this particular post hoc analysis was to take out measures of pain appreciation and to look at how they changed over time. So we looked particularly at the patient's global assessment, and we focused also on the minimal clinically important difference in the patient's global assessment. We also looked at much better improvement. That's a definition of more than or equal to 2-point reduction and more than or equal to 33% reduction from baseline in the patient's global. We also, however, had a look at additional endpoints, including the short form survey SF36 question 7 and the BASDAI question 2 and BASDAI question 3. So these are questions specifically focused on appreciation of pain by patients. Now, if you want to look at the poster and turn your attention to figure 2, you'll see here that we're annotating the proportion of patients achieving at least 30%, 50%, 70% reduction, or the minimal clinical important difference, or the much better improvement in the patient's global. And you can cast your eye across the graphs, but what you'll see is that there is a very significant improvement in those patients receiving both doses of upadacitinib. And when we look at those patients in receipt of adalimumab, you can, from the SELECT PSA-1 study, you can see that, if anything, there are numerically higher improvements in pain reduction in those receiving upadacitinib than adalimumab, but certainly clear differentiation from placebo. Now, if you look in figure 3, you can see the same data, but now depicted for the SELECT PSA-2 study over 24 weeks. And I should have said for both of these, this is a non-responder imputation. And once again, you can see that both doses of upadacitinib achieve significant improvements as compared with placebo, this time, remember, in a patient subpopulation who had previously failed biologic disease-modifying anti-rheumatic agents. And now turning finally to figure 4, you see here a depiction of the changes that occurred in BASDAI question 2, BASDAI question 3, SF36 question 7, and SF36 question 8 respectively. In the top panel, you're looking at the improvements in the SELECT PSA-1 study, in the bottom, SELECT PSA-2. And then if you look on the right-hand side, you see these changes depicted over time. And the take-home from here is that there were significant improvements, which were most notable for the upadacitinib groups. And in the overall analysis, we see that probably the 30 milligram group has outperformed the 15 milligram group, although both those groups outperformed placebo. So the conclusions I would ask you to take away from this poster are that there were greater proportions of patients with active psoriatic arthritis receiving upadacitinib as opposed to placebo, were achieving a rapid and significant and clinically meaningful reduction in their pain. And we saw this across a range of evaluations. And actually, it looks as if the 30 milligram dose group achieved improvements in most pain assessments as early as week 2. So this is a really remarkable early onset of action, and that was numerically greater than the adalimumab recipients. And this does suggest that upadacitinib is going to be a useful medicine in the management of people with psoriatic arthritis. As always, we have to balance that against the safety profile for this medicine, which continues to emerge. And I think in clinical reality, it'll be the 15 milligram dose that we should be paying most attention to. So thanks very much for your attention. I hope you found that poster review interesting. And as ever, if you are interested in more detail, please go back to the poster itself for a review of the data as presented there. Thanks very much indeed.
Our next presentation is from Professor Xenfon Baraliakos, who summarises the impact of filgotinib on structural lesions in the sacroiliac joints in patients with active ankylosing spondylitis.
Hello, my name is Xenfon Baraliakos. I'm a rheumatologist working in Germany with a particular interest scientifically in spondyloarthritis, especially axial spondyloarthritis and imaging. And the data that I am presenting or discussing with you today are data that we have presented at ACR 2020, the virtual congress that just went over. And we tried to report on the information about whether or not there is any correlation between MRI lesions, structural lesions in the MRI of the sacroiliac joints and clinical endpoints in patients with active ankylosing spondylitis under treatment with filgotinib, a JAK inhibitor, over 12 weeks. The reason to do this study or to do this analysis was that we do know very well that there might be some correlation between clinical characteristics and MRI findings for inflammation, for bone marrow edema. However, we also know that ankylosing spondylitis is in the long term associated with decrease or limitation of mobility and function. And therefore, we wanted to know whether or not also the structural lesions that come after inflammation and are indeed affecting the bone, whether or not these correlate with the clinical endpoints of the patients that matter to us, at least from the clinical point of view. We took patients who participated in the Tortuga trial. Tortuga trial is the trial that evaluated the effect of filgotinib in those patients with active ankylosing spondylitis in a phase 2 trial so far. We had all their clinical endpoints available that could be assessed in a randomized placebo-controlled trial as we know them. And we also had MRIs of the patients that we evaluated. Overall, we could include 116 patients, 58 were treated with filgotinib and 58 were treated with placebo. For the study that I'm presenting here, we had 107 patients, more or less similar numbers, 55 and 52 with filgotinib and placebo respectively. And we had the MRI scans of a large part of them, this means 87 patients, who were put into the analysis. So we indeed evaluated those with clinical findings and MRI, full MRI sets. There was no difference between the patients who were not included in the study and those who were included in the study. So MRI was not a criterion of having maybe a different outcome or a different baseline finding. Going over to the results, we have seen that indeed inflammation that was previously reported, inflammation has decreased significantly already after 12 weeks of filgotinib treatment as compared to placebo. We've also reported that from the structural point of view, there have been some significant changes also in those patients who have been treated with filgotinib, in terms of them having less erosions over 12 weeks and more fat metaplasia, especially in the area of the joint space, what some people also call backfill. This means there has been kind of direction towards metaplasia of the tissue, most probably also towards new formation of tissue or even transformation into the fat, which again will later on may show some new bone formation. And when we applied all these findings, this means the correlations to erosion, to fat metaplasia, even to within the joint space or without or directly at the joint space within the bone, or even ankylosis, we were not able to find any correlation between the baseline characteristics from the clinical endpoint of view and the outcome of the MRI, either when we evaluated only the baseline or the follow-up outcomes, which again means and brings me to the conclusion that after 12 weeks of treatment, we were able to show associations of treatment to the MRI findings, both for the inflammatory lesions, again shown earlier, but also the structural lesions. But we did not show any significant correlations between all the clinical outcomes that we know. Again, these were the obvious ones: ASTAS, BASFI, BASMI, CRP, and the MRI outcomes in terms of chronic changes. We believe that we may have a first signal here that indeed the improvement or the change in function and mobility may be more associated with the treatment itself and not so much with the changes, at least not on the MRI. However, of course, we also need longer term data beyond those 12 weeks to prove this theory that has been shown here as a signal, and this data will be retrieved in the long-term study. Thank you very much.
The final presentation is from Professor Buch, who will now present a phase 2b study evaluating the BTK inhibitor Ebrutinib.
So thank you for the opportunity to present this abstract. This abstract reports on a phase 2b randomized double-blind study in patients with rheumatoid arthritis and an inadequate response to methotrexate, evaluating the safety and efficacy of Ebrutinib. The pretext or the context of this study is that we all recognize the role of B cells in the pathogenesis of rheumatoid. Bruton's tyrosine kinase, or BTK, is involved in the activation and proliferation of B cells, as well as actually cells within the innate immune system, and therefore presents a rational therapeutic target in the treatment of rheumatoid arthritis. Within this, Ebrutinib specifically is a highly selective oral BTK inhibitor because it has its action on both B cells and myeloid cells that I alluded to earlier, and has actually been evaluated in other immune-mediated diseases. So in this study, just under 400 patients, 390 patients were randomized to either Ebrutinib 25 milligrams daily, 75 milligrams daily, or 50 milligrams twice daily, or placebo. And these were patients who had a diagnosis of rheumatoid for at least 6 months and were on a background stable dose of methotrexate for at least 8 weeks. And the objectives were to evaluate the efficacy, the dose response, and the safety of Ebrutinib compared to placebo. About half the patients actually also participated in our MRI sub-study that provided additional secondary endpoints. The primary endpoint of the study was ACR 20 using high sensitivity CRP at week 12. And there were, in addition to the MRI endpoints, other clinical endpoints: disease activity score CRP, low disease activity and remission, but also safety evaluation, so adverse events and safety adverse events. So of the 390 patients that were randomized, just over 90% completed 12 weeks of treatment. The mean time from diagnosis was approximately 6 years in all the groups, and essentially the characteristics at baseline were balanced across all the treatment doses and placebo group for both demographics and disease characteristics as well. The top line of the study result is, in essence, that the primary endpoint wasn't met. That is, Ebrutinib was not shown to demonstrate higher ACR 20 response rate at week 12 compared to placebo. And if you look further in the primary endpoint results, it's interesting, there was a really marked placebo response. So 50% of patients in the placebo group achieved an ACR 20 response. This was much higher than was expected. If we look at the secondary endpoints, again, there were no significant differences between placebo and the Ebrutinib dosage groups. There was suggestion, however, of some numerical and meaningful difference in the sense that DAS28 CRP low disease activity at week 12 was approximately at 20 to 25% in the Ebrutinib treatment arms compared to 7% in the placebo arm, and there was significant reduction in high sensitivity, median high sensitivity CRP change between Ebrutinib and placebo, and this was nominally significant. So the other results were, as I mentioned, in relation to the MRI sub-study. And interestingly, again, both placebo and Ebrutinib showed significant reductions, and this was looking at synovitis score, osteitis score, and erosion score. So again, the placebo also showed significant reduction, and this was in the range of about 82% change from baseline with placebo compared to 86 to 91% in the Ebrutinib arms. Importantly, in the both clinical endpoints and the MRI, there was no dose difference noted either in the Ebrutinib arms. And then the final results were safety. So whilst there was no significant difference in Ebrutinib and placebo in terms of efficacy, there was a reassuring safety profile. There was also no difference in number of adverse events, no significant difference in the type of reported treatment emergent adverse events, and again, no dose effect of Ebrutinib. Grade 3 events were very infrequent. There was only one grade 4 event, and minimal incidence of liver function test rise. So to summarize and conclude, in this phase 2 study of Ebrutinib in patients with rheumatoid that had an inadequate response to methotrexate, the primary efficacy endpoint of ACR 20 response wasn't met, and there were no MR differences either and also with the secondary clinical endpoints. This is in the context of a very high placebo response. It's not clear as to the basis of this, and it's also not clear as to the basis for not seeing any clear significant benefit of Ebrutinib when compared to other BTK inhibitors that have also been evaluated. It was, however, safely tolerated, but in essence, the conclusion would be that whilst safe, this study suggests that inhibition of BTK using Ebrutinib isn't sufficiently effective in reducing signs and symptoms over a 12-week period. Thank you.
Thank you for listening to this edition of Insights at ACR 2020. Make sure to subscribe to the CSF podcast channel on Apple Podcasts, SoundCloud, or wherever you get your podcasts from, so you don't miss out on our other ACR 2020 content, like our condensed daily highlights of the ACR Congress. If you found this informative, why not listen to our regular podcasts, which include author interviews and a monthly review of the latest cytokine signalling papers, hosted by the CSF chairman, Professor Iain McInnes. You can also visit cytokinesignaling.com for access to a wide range of free educational resources, including monthly slide summaries of the latest papers and accredited CME courses.